In this presentation, I will talk about workplace curriculum design and how we can connect theory to practice. First of all, I need to explain that I wear multiple hats. I'm an obstetrician working in a tertiary care hospital, and I, of course, not just look after patients, but I also teach and educate in that capacity. I'm a researcher of workplace learning at Maastricht University, interested in how people learn from the work that they do. I'm also the director of the School of Health Professions Education, and a fourth role that is important for this presentation is that I'm the chair of the revision of the Dutch curriculum for obstetrics and gynecology. All of these different perspectives come together when thinking about curriculum design and how we can learn from our research in that area. The challenge that I'm going to address is how can we educate healthcare workers for the future in the present? And that is quite a challenge. So where to start? Well, I say let's start here. Let's start with what we know. And what we know is that if we want to teach people how to practice, the best place to do that is in actual practice. Not just by letting them be there, but through deliberate practice. And Billet and Erickson have published extensively on these different topics. What we also know is that competency-based education is the basis from which we start, from where we think about education nowadays. And I will talk about that later a bit more. There are also developments in terms of assessment and feedback that we need to take into account. And in general, if you look at health professions education research, there's a lot more clarification research nowadays. So research that not just explains to us what people are doing in education and that they think it works, but why it works or why it doesn't work, and it helps to build the underlying concepts. That is vital, because we are in a science where we are trying to apply what we understand to practice. So we need to connect theory to our practice, to improvements in practice, and do research on that and connect that back to theory. I'll come back to this later because this is vital. And that's coming from architecture. Here you see a rather beautiful building, a shopping mall. You can see that if you would enter this building, the escalators just invite you to move up to the higher floors and to explore the shops that are there. However, this can also be organized differently, is what people within architecture have been thinking lately. And instead of creating buildings that function well, we could also create buildings that function well and invite people to use the building in a healthy way, in an active way, in a way that supports a better lifestyle. And then you get designs like this, where instead of the escalators or the elevators being the center of the building and the most inviting thing, the stairs invite you to use them. And if you walk up the stairs, there are even opportunities for some social interactions. Instead of artificial lighting, there's lots of natural lighting. There's a connection through the glass facade with the outside world, with the green environment. And it invites people to engage in a more active, a healthier lifestyle. And that is part of how this building was designed. To not just make it function well, but also to think about how people will be using the building and to design it in such a way that you invite the users to do what you think is right. But this is applicable to how we think about curriculum design for workplace learning as well. And I will illustrate that, but first I need to discuss with you how we are currently doing in terms of designing curricula for the workplace. And as I said, competency-based education is an important starting point. And I want to start with a definition provided in the article by Holmboe, Sherbino and colleagues. And they explain that competency-based medical education, or competency-based education in general, has a number of fundamental characteristics. Importantly, It is a shift in emphasis away from time-based programs based solely on exposure to experiences, such as a clinical rotation, and it moves away of that perspective in favor of an emphasis on needs-based graduate outcomes, authenticity and learner-centeredness. Very important here is that we are clear not just how long you will stay in a certain place and participate, but why you are there, what we hope that you will gain from the experiences there. And we describe that by describing the outcomes that we expect learners to obtain in those workplaces. It means competency-based education. It means both a holism and a reductionism approach. In other words, we do think about the learner as a whole and how they are developing to become competent physicians or nurses or midwives. But we also need to break down some of the things that they need to learn to a more reductionistic approach to be able to explain what the steps are that they need to take along the way to get to where they need to go. So the issue is when and how to apply these interconnected philosophies appropriately. That's an important challenge for competency-based education, when to become more granular and more defined in terms of outcomes, and when to take a more holistic approach and think about the development of the professional and the way in which that professional is going to contribute to a health care workforce fit for the future. Now, from this starting point, let's briefly discuss how we are going about designing our curricula, our workplace curricula in the 21st century. And next to CBE, competency-based education, there are two other elements that I will introduce on the next slide, and that is the entrustable professional activity, or EPA, most of you will be familiar with, and a programmatic assessment. Those are important building blocks for curriculum design. So, in one slide, Curriculum Design 101, I'll quickly take you through the basic principles. So here is the competency framework, and one can use defined competency frameworks, for instance, the CanMEDS rules or the ACGME competency framework that the Americans use. You may have your own particular competency framework, but it will usually be a rather abstract and general description of the different competencies that an individual healthcare worker needs to develop. So in order to be able to use that in actual curriculum design, it needs to be made more specific. And if you look at the CanMEDS, the way that they do that is by describing a number of key competencies underneath each of the 7 main competencies. Within those key competencies, there will be descriptors of actual behavior, so the learning objectives that you want people to obtain. So if you do that, then you get a number of competency descriptors that are part of the building blocks of a curriculum. Nowadays, there's often a distinction made that the learning objectives that you want people to reach are different for different stages of their development. So if you also include that, and you create competency descriptors for different stages of training, you get what we call milestones. Of course, it will lead to more milestones than the previous version without taking the stages of training into consideration. But again, you end up with a nice list of behavioral descriptors that are the objectives for learners in light of the competency framework that you use. The next element is that you need to start with the content of your profession, be it nursing, physiotherapy, general practice, surgery, you name it. What you do is you describe discrete tasks or responsibilities that supervisors can entrust a competent trainee. So you sort of put boundaries around parts of the profession, and you say, well, if we train them within these confined groups of tasks, then it is a helpful organization of our profession that we can use to say, okay, now you're able, because you're more competent in this area, to function with less or with more independence, with less supervision. So that's the basic definition of creating EPAs and trustable professional activities for your profession. And again, you create a list, and having your milestones and having your EPAs allows you to create a table where you say, well, within this EPA, these milestones are relevant, and I will focus on obtaining or having the learner obtain these particular milestones. And if they do, then they are at the stage where they can be entrusted with working with less supervision in that particular EPA. Now, how to objectify if they have reached that situation? There is not one test that will allow you to say yes, they have reached that stage, because there are different elements to what the milestones describe, and there are different characteristics to what the different EPAs will be about in terms of their content. You will probably need different types of assessment and at multiple moments in order to be able to have a valid representation of how somebody is functioning. And that is the underlying idea behind programmatic assessment, combined with the fact that for all of these different assessment moments, you're not just using them for decision making based on the aggregated information, but you also want to have each separate assessment be helpful for the learner, that they can use the information that it yields for their learning. Well, this is Curriculum Design 101 in the 21st century. You have your competency framework, you have your EPAs, you create your table where you match them, and you design a system of assessments, a program of assessments, so that you can help learners learn and help assessors assess if people are on the right track. Now, with this approach, we have been using competency-based education, EPAs, and programmatic assessments for between 10 to 15 years in different variations in the Netherlands. Now, how are we doing? This is research by Nienke Renting from the north of the Netherlands, and she explored how programs informed by competency-based education, meaning CanMETS in the Netherlands, operate in clinical practice. She published her work in a number of journals, but in summary she found that competencies other than medical expertise remained underexposed, were often constructed in feedback in such a way that the original intentions were not met, and ultimately did not seem to have become an integral part of practice in the clinical workplace. So although we all understand and now know that medical expertise is not the only thing that is important, in our current training, the way in which we have designed the workplace curriculum isn't helping us to allow those other elements, those other roles, to feature in how we train, supervise, and assess residents. Now, research by Karsten van Loon. I'm one of his PhD thesis supervisors, and he studied EPAs and how they function in clinical practice. He found that faculty do appreciate how EPAs formalize and structure progressive independence in practice. Also, that it does bolster the bureaucratic side of education. At the same time, for residents, EPAs can help structure their learning, but few residents actually use it for this purpose. Overall, he found that there is rather a disconnect between the experienced usefulness of EPAs for the formal entrustment decisions and the informal entrustment decisions that actually determine what goes on in practice. One more study, and this one is not from the Netherlands but from Canada. Martin and colleagues in McMaster studied the impact of EPAs and entrustment scales on feedback and learning processes in the clinical setting. They too find that EPAs are potentially effective drivers for feedback and learning, but also that the use of entrustment, based on the EPA organization, as the outcome may impact trainees' motivation and feelings of self-efficacy, and that enhances the tension between learning and performing. So the inbuilt dual aim of having assessments within EPAs that tell you something about how somebody is doing, but that at the same time should inform the learner on how they can continue to learn, is a tension that doesn't work well in practice. And a review by Schut and al. Published last year in Perspectives on Medical Education on Programmatic Assessment also recognizes this same tension and the challenge that many people in practice have, residents and faculty, with combining both formative and summative goals of assessment. So if we take stock of what we know from how our current curricula that we have designed actually work in practice, we do see that there are a number of issues. And the question is, what do we do with this? What can we learn from this? In my opinion, this is not just an implementation issue, an argument that we often hear. We need to focus more on implementing competency-based education, on implementing programmatic assessment, on implementing the use of EPAs, for instance, through faculty development. I think we have an underlying issue that we need to address as well. We have created, with our curriculum designs, a well-constructed building with all of the necessary functions. But we have not taken into account how people are actually using our building. And what we want is not them using it in a passive way, but in a much more active way, to create active learners that also help to develop an environment where everybody recognizes that they are learning and that they can improve together. If we can achieve that, if there's a way in which we can design our curricula the same way in which architecture is using more active design principles in buildings, we might create an environment where we are not just focusing on creating competent individuals, but actually achieving better healthcare. Because at the moment, I think there is too much focus on training for competence, on producing competent individuals, and that stands in the way of educating for good healthcare, for the best possible healthcare. And that may sound strange, because competent individuals are indeed required for good healthcare. But we need to keep in mind that competent individuals isn't the same, or educating for competent individuals isn't the same, doesn't equate to educating for good healthcare. It's a prerequisite, but it's not enough. And the paradox here is that if we focus too much on educating competent individuals, it will actually stand in the way of educating for good healthcare. And I will explain why. Based on my own research, on research of a lot of colleagues in workplace learning, but also in education in general, I recognize that there are a number of elements that we need to take into account when thinking of workplace learning in healthcare. And I've summarized these elements in this slide. Yes, it is about individuals who want to become part of a profession, and they need to learn what it takes to become part of that profession, the knowledge, the skills, the norms, the values. So it's about their individual trajectory to become a member of that profession. And at the same time, they are doing that in an environment that allows them to be part of a healthcare team. And that team is part of an organization, a healthcare system, with its main focus is patient care. So as they are part of a team and participating in patient care, they are also part of a larger healthcare system. And it is these 5 elements that have a number of issues and topics and different layers underneath them that leads to the context within which we need to organize workplace learning and the context that we need to be mindful of when designing workplace learning. We need to focus not just on the individual trajectory of that person becoming part of a profession, but we also need to support how they participate in the team and how they contribute to the collective effort of the healthcare system of which that team makes a part, that together contributes to good patient care. So if you look at the literature and if you look at research on these different elements, then there are a number of interesting issues and topics that come up. With regard to the individual, things like ability, motivation, their identity development, but also more personally their ambitions. There needs to be much more attention in medical education and in health professions education in general for the well-being of our learners and our future professionals. In terms of the profession, as I said, it is about the knowledge and the skills, the body of knowledge and skills of that profession, but also the development of that profession, the underlying science, the innovation, particular values and norms. For teams, we need to be mindful of intra and interprofessional dynamics. Things like collective competence and interdependent performance are a challenge in assessing and supporting learners that work within teams. With regard to the healthcare system, it's important to recognize that at that level, people often talk about human resources and about employees and not always recognize that employees are also learners, whether or not they are part of a formal educational program. The patient wants the best possible care, but they also want a humanistic approach, a personalized plan. And they want to feel that they can trust the individual, the team, and the healthcare system that is looking after them. And if they feel that trust, they are willing to contribute to education. But we need to be very mindful not to damage that trust. Knowing these 5 elements and seeing the different issues and topics within each of them, how can we translate that to curriculum design? Well, there are 4 design principles that I want to present to you, and I'll keep it brief. There's lots to say about each of them. First of all, we need to integrate learning and working. We need to make learning the attractive option in our everyday work. Again, think about the architectural parallel that I draw earlier. There needs to be a safe and constructive learning environment. Everybody is learning, but everyone should also be recognizing that they are learning as individuals, as teams, in order to provide good care now and to show to everyone as role models, as colleagues, that they are open and willing to continue to learn. And that also sets the example that we need for our future healthcare professionals. As organizers of education, we need to trust in people's motivation to learn. And the trust is fueled if we can give them responsibility for their own learning. If we build in room for choices, for their own development, for chasing their own ambitions and making use of their motivation to become the best possible healthcare professional that they can be. We need to also recognize that the workplace has a lot to offer for people to learn, but not everything. So there needs to be some support and there needs to be a supplement of learning for those elements where the workplace is just not providing the exposure or is not the ideal environment that we want it to be yet. But the ways in which we support and supplement learning in the workplace needs to be done carefully. We need to make sure it's simple, it's understandable, and that people recognize that what we are adding to it is actually making their practice and their learning in practice better. So the KISS principle really applies here. Now, I'm also, for the past 3 years, chair of the redesign committee for the National Curriculum for Obstetrics and Gynecology in the Netherlands. And we've been trying to use these insights in the redesign of our own curriculum. And we've said, well, we need to think about 3 domains of learning for individual healthcare professionals. And you will recognize the connection with the elements that I showed you before. The domains are knowledge and skills, work-related competencies, and we've identified 3, being able to provide patient-centered care, to work in a team, and to contribute to the functioning of the system that you're working in, and to work well within that system, also called system-based practice. Those are the 3 domains identified as work-related competencies, the three elements identified as work-related competencies. The third domain of our model is personal and professional development. Important in the sense that we want attention for individual well-being, for a sustainable workforce, but also for the way in which people contribute to the development of the profession. We made another distinction, and that is to say within these three domains, there is a difference between accessible outcomes and topics or issues that require continuing development, but for which we are not going to say this is the norm, this is the desired outcome. We will allow people freedom to decide in which direction they want the development to take, as long as they pay attention to the particular topics that we have said are important to pay attention to. So particularly for knowledge, skills, and aspects of the work-related competencies, we can be very clear on what the outcome is that people need to obtain. And for instance, within teamwork, there are things that you just don't do and that you should do in order to contribute to the effective functioning of the team. But teamwork is also a nice example where different healthcare professionals will contribute in different ways fitting their personality and their background and their experiences. And there needs to be room for that development. And it needs to be clear that there's not a particular outcome that you need to obtain and then you can move on learning other things. Now, you need to continue throughout your career to pay attention to how you function within a team and how you contribute to the effectiveness of that team. And that is an element of continuing development that we want to see. So within our curriculum design, we have distinguished between EPAs, related to what we've discussed before and what is present in many curricula now, and themes. And I will give you an example of the 4 themes that we have used. These are sustainable work satisfaction and engagement, care that matters, care that works, and knowledge and innovation. And underneath each of these 4 themes, there are 2 to 4 particular topics that we have described that we want people throughout their training of 6 years in obstetrics and gynecology in the Netherlands to pay attention to. And they need to pay attention to all of these topics at a basic level. And we say it's good enough if they, together with their supervisors and the context that allows them to explore particular areas within those topics, have paid attention to them. If you do not pay attention to them, then that's not satisfactory. But we do not say this is the particular endpoint. And if throughout your training you want to focus more on aspects related to knowledge and innovation, or care that works elements, such as introducing new innovative surgical techniques, then there is ample room to do that. And it will allow you to also differentiate yourself a bit from your fellows, from your peers. And that provides room, that provides motivation, but it also allows for the development of healthcare professionals with a strong foundation and with the additional abilities to continue to contribute to good healthcare in the future. At least that's what we hope. So the basis here is creating a feedback culture where everybody is learning, and we've highlighted that in particular within our curriculum description, what is necessary to achieve that. And we've been clear where feedback is mainly for assessment purposes and where feedback is only for formative purposes. So we've tried to distinguish that as well, and if there's time I can say more about that later. Finally, if you think about the elements of workplace learning that I've described earlier, there's another dimension when creating curriculum design. It's not just trying to cater to all of these elements and provide a structure within which people can learn, but it's also moving from the concepts and the literature and the ideas behind it to a practice. And that's where designing comes in. That's where the e-portfolio plays an important role. And that's also where faculty development and learner development are essential. So what I propose is that we refocus on what we try to achieve with competency-based education, which is to prepare a future-ready health professions workforce that serves patients and society. And that means taking our own research seriously. We need to recognize the undesirable side effects of our current strategies and use evidence-informed alternatives to continue to develop our practice and to continue to study what the effects are so that we can further enhance our theory, our thinking, and again, our practice. So my wish to you is stay curious and stay critical, and thank you for your attention.